Welcome. Come with me. The doctors will see you now.
Hello and welcome back to Fast Talks with Family Docs. I'm Dr. Phil Palmer here with your favorite co-host.
I don't know about that, but I'm Dr. Veer Vadala. On this episode, everyone, of Fast Talks with Family Docs, we're excited to welcome Dr. Rachel Franklin, a family medicine physician with over 2 decades of impactful service in healthcare. Dr. Franklin is a Regents Professor and Vice Chair in the Department of Family and Preventative Medicine at OU College of Medicine, Family Medicine Department, where she combines her passion for patient care with teaching and mentorship. She has most recently served as Associate Chief Physician Executive for Care Delivery Models at OU Health. Prior to that, she was the Physician Executive for the Community Health and Primary Care Division of OU Health, where she oversaw vital clinical operations, including OU Edmond Medical Center, the OU Emergency Department and Urgent Care Centers, primary care, telehealth, and integrated community health initiatives. Lots of stuff, Dr. Franklin. Dr. Franklin's interests are diverse, covering women's health, pain management, pediatrics, and health advocacy. She's been recognized with multiple awards, including the OU Medicine Award for Outstanding Patient Service, and is a fellow of the American Academy of Family Physicians. Beyond her clinical administrative roles, Dr. Franklin is also an accomplished author, having written Expecting Twins, Triplets, and More, A Doctor's Guide to a Healthy and Happy Multiple Pregnancy. She will also be serving as our immediate next OAFP president, and we're really looking forward to exploring her insights on the future of family medicine, patient care, and evolving healthcare landscape. Dr. Franklin, thank you so much for being here.
Thanks for having me, guys.
Unfortunately, that's all the time we have for today.
Oh my gosh.
No, we're really glad you're here. Rachel, thank you for taking the time to sit in with us and chat.
Thanks for having me.
Well, Dr. Franklin, I think I'm going to start off with the questions. You served as the physician executive for community health, at OU Health, and we feel like it's a job that has a wide range of roles. So how did you first get involved in healthcare leadership per se, and what kind of inspired you to pursue a role in healthcare administration?
At this point, I was 6 years old when I decided to be a doc.
Yeah.
So much of it has had to do with wanting to take care of people better. Mm-hmm. So I spent about 10 years on our practice board of directors, trying to help OU physicians to do all of our care for patients better, kind of help run the physician practice. And when OU Health came online, there were a number of opportunities to serve. One of the areas that family medicine can serve best is by helping out in the community. So when you talk about what we do for a living, right, we're passionate about not just the care of that one patient, but that patient in the context of their community, their family, the environment within which they work and live and have their lives.
Right.
And that perspective is one that's often lost in a large subspecialty heavy organization like many of us work in. So the opportunity to bring that community-based perspective, the family perspective, was just an opportunity that I couldn't pass up. So that's kind of how that particular role happened. It has been an absolute honor, and I learned a ton.
Yeah, that's amazing. What are you going to do next?
Right now, I'm working with the Oklahoma Primary Healthcare Improvement Collaborative. I think you've talked with Dr. Steve Crawford about his work in that area. I'm the clinical co-director, so I'm grabbing his coattails and kind of learning the ropes.
Yeah.
We're working on a statewide program. We hope to obtain a grant that would allow us, with a multi-stakeholder council of folks all over the state, to develop initiatives to address behavioral health throughout the state, access to care for mental health and those sorts of things. So if we are fortunate to receive that grant, we will be working to expand OFIC's prior activities in practice enhancement to develop kind of like the agricultural extension service, but for medicine, so that we can actually develop a program that practices can participate with or simply receive information from, or partner with other organizations to help bring services to their patients in their communities throughout the state.
Yeah, I had the chance in the past when that entity was looking at cardiovascular disease and interventions related to lipid control and blood pressure control to be a part of going out across the state and interacting with docs. And that's a fascinating model of like that county extension agents that in that local county then would go out and visit with all the farmers and bringing that same role to medicine is a great idea.
Yeah, what's great about it is that that was Healthy Hearts for Oklahoma.
Yes.
I was also an academic detailer for that. It was fantastic. I saw all parts of Oklahoma that I'd never visited
so
before.
Much fun.
That's so
It was
cool.
great. And to see those practices where the family medicine doc is hanging on and is the key, the cornerstone of that community, right?
Yeah.
They're really making a difference in their communities and to be able to bring the help that they need.
Yeah, give them the resources they're
Exactly.
desperately looking for.
So this will go beyond, if we can get this up and running, this will go beyond academic detailing. This is not an expert coming down from a university or a big health system telling people how they should do their jobs. This would actually be working to develop policy or make sure legislation supports the kind of care that we need to provide for our patients. There would be an aspect of education and of, bringing up practice standards everywhere so that everyone has access to everything. But it's really an exciting opportunity.
I agree. I agree. It's exciting to hear that in the works. So, Dr. Franklin, as you have this role and as you'd mentioned, trying to promote primary care in an institutional setting where there is so much subspecialty focus, what are some of the challenges you've had advocating for primary care, and what are some rewards that you've had in this role, and has your role evolved over the last several years that you've been doing this?
Nationally, these roles evolve. One of the things that we are aware of that family medicine can help lead is the evolution towards value-based care. So the healthcare financing organizations that you can read their white papers and their executive summaries, and these are the things that large organizations, CFOs, are also reading. They are getting the understanding that payment structures are changing and that payers will be paying more for how well you care for a patient, what that patient's outcomes are, as opposed to the piece-by-piece, fee-for-service, I did this, you pay me model. And one of the things where family medicine is really strong is an understanding that the care of a patient is longitudinal. It is not about the one episode of care. So family medicine has great opportunities to really lean in their organizations and help the organizations understand when that patient leaves the hospital and now we're going to be measured on what happens in that next 30 days or 90 days. That happens within the continuum of care. That's not the episode that happened in the hospital. That's what happens in our offices. Right. That's what happens with our clinical teams that provide that medication reconciliation and the education about the new diagnosis and the support services that are necessary for that patient to succeed. As payers move further and further into this realm, it provides more and more opportunity for those of us that understand that continuity breeds success to have an influence.
Yeah, and I think that's one of the keys that hopefully family medicine can be integral in that, because, that model we had in the past allowed that to happen is you took care of your patient in the hospital. So you had that continuity when they came back out. And not everybody wants to do that, and not everybody can do that. And most systems now have hospitalists. And so finding that way to engage and make a really healthy, dynamic transition, educating the patient in the hospital and continuing that as they leave, and partnering with them to work further in their health care. And you're right, I think that is exactly where the payers are pushing, and we've got to be ready to partner with them and bring better health to the people of Oklahoma.
I would also argue that that is another reason for family medicine to lean into the leadership. You are a member of a medical staff somewhere if you are part of a health system. In the smaller communities, you know those other players in your community. You know who you're sending your patients to. Leaning in and offering your leadership and your knowledge, your skill set as it relates to supporting the care of that patient is really going to be valuable and provides an opening for any of us in our circumstances to be able to affect that improvement in our patients' care.
Yeah.
Well, it's such an important statement, Dr. Franklin. I think more and more family medicine providers need to step into leadership roles, because if we're not at the table, right, how are we going to have any influence on the outcomes? And, where you're talking and talking about value-based care, I think we're going to be, expecting a lot more focus on preventative medicine. And the biggest thing from family medicine is we do have a lot of focus on primary prevention, and you being vice chair of family and preventative medicine, how do you think that role is going to change in the future in the healthcare landscape? And have you had any, in your experience, any routes that you have found more effective to kind of promote that primary prevention?
There are areas that payers care about and areas that payers, unfortunately, are rather short-sighted about.
Yeah.
The areas where they're short-sighted are, unfortunately, some of the areas we really care about. Mm-hmm. We understand that spending years helping a patient live a healthier life leads to that patient having a healthier life. Right. In current payment methods, although those are transitioning, if you are only on an insurer's books for a year, then why would I want to pay for your obesity treatment?
Yeah.
Why would I want to pay for your whatever that will have a long-term effect for you, your family, for the future of generations, when all I'm really going to get out of it is cost?
Yeah.
I don't get to see that benefit down the road. And I think as we evolve payment models, we will find that the rewards that payers provide, especially CMS and others that are paying payers to pay us, mm-hmm. I think as policy changes, that hopefully will change.
Yeah.
And I think it's trying to help the payers understand there is no one insurance entity that over time is gaining all these patient lives.
Mm-hmm. Right.
They're going from one to another. They're rotating around. And so, yes, it is true that if you're investing money in someone's obesity treatment or whatever the case may be, you don't get the gains of that 15, 20 years down the road. But if all the insurers recognize the value of this, then whatever other company's investing that now, you'll get those patients 15 or 20 years down the road. It's all going to balance out because everybody's not moving to one payer who's getting the benefits. They're moving between all the payers.
Well, and writ large, we can't afford the health system full of sick care.
Right.
Yeah.
We can't.
No.
That's actually one of the things that the healthcare finance folks are looking at in their journals is we have a very short time frame before we can't afford to care for patients who are sick and unhealthy anymore.
Yeah. It's so interesting talking to you too, because I don't think a lot of us providers even think about that insurance perspective, because if they're rotating insurances, they wouldn't be. Wow, I didn't even think about that.
I mean, think about what happens every January 1st.
Yeah.
Every January 1st, you are the family doc, you write the script the patient has been on for 10 years.
Yeah.
You know, it's in your records that they've tried the other 8 medicines and something didn't go right, and this is the medicine for them.
Yeah.
What happens every January 1st?
You get to tell somebody else the same story.
That's right, because their insurance changed or the policy changed. Mm-hmm. So, this is something that just isn't sustainable. And so a lot of the advocacy efforts that happened this year had to do with prior authorization reform and some of those other wins that family medicine had here in Oklahoma. That's why we continue to advocate for our patients to make it easier for them to get what they need.
Yeah, definitely. Well, we're going to take a break right here. And Dr. Franklin, thank you for joining us. And followers of the podcast, we're grateful for your time and attention to this podcast. And we'll be back next episode with some more conversation with Dr. Rachel Franklin.
Thank you for joining us today. The doctors would like to see you back for another check-in. Please choose to follow our podcast and you will automatically be notified when it's time for your next appointment.